Good afternoon, everyone. My name is Yvette Kelly with the Managed Care Technical Assistance Center, and I'd like to welcome you to today's Children's System HCBS Modifications webinar. Before we get started, I'd just like to review a few housekeeping items. The slides and recording from today's webinar will be posted on our website, mctac.org. And also upon the conclusion of today's presentation, there will be a brief question and answer period. We're asking that participants submit their questions utilizing the chat box feature located on the right-hand side of your screen. If the box is not visible, please click the dialog bubble towards the bottom of the screen and the box should appear. Again, please feel free to submit your questions at any point during the webinar. As always, information and timelines are as current as of today, and for official guidance, please refer to the provider and billing manuals. So today's webinar will provide an overview of the presentation as well as an overview of the process for authorizing the various modifications. We'll also discuss how each of the modifications are reimbursed as well as review the service descriptions. Lastly, we will review some of the resources that are available, and as I mentioned previously, there will be an opportunity to ask questions at the end of today's presentation. So to get us started, I'm going to pass it over to Colette Pullen from the Department of Health.
Welcome, everybody. We know this was a long-awaited webinar, so appreciate everyone joining us today. And we have a number of people in the room from our previous Care at Home waiver, as well as our transportation gurus and folks. So we're going to go through some information. Much of this information will hopefully be an update for you or familiar. And I will remind folks that we have our HCBS manual out there that gives a lot of information. So appreciate everybody's attendance. I'm going to do the opening slides and then turn it over to Tanya Rollison, who's going to go over the step-by-step process. So our goal today is to really talk with our health home care managers and our independent entity of CES. I know we probably have some local departments of social services and other folks on the phone. Our goal today, our overall goal, is to review the roles and responsibilities of the care manager, CES, and our local departments of social services, and how the services of the environmental modification, vehicle modification, and assistive technology will be authorized and approved, and how those services will be connected to children and families. And again, there will be some new elements we'll go over today. The Department of Health and our Division of Long-Term Care have been working really diligently to make sure that processes are streamlined and that they're consistent. And that was really our goal as we consolidated the previous 1915 C6 waivers. And as we're pending the launch of CFCO, we wanted to make sure that there was one process. So, you know, each of the waivers had a little different version if they did have these services. And we wanted to make sure that everything was consistent as we move forward. So the things that you hear today should continue even when CFCO launches, unless we are streamlining or addressing some issues that people have brought to the attention of the state. And, you know, I think it's really important that everybody understands, and maybe some of our care managers who weren't previously working in waivers understand the vital importance of these services and what the goal is of these services. And it's really to assist and enhance the daily living and the activities for children and families, and to make them more self-sufficient, a little more independent if they can, or just overall improving their health. And then just, you know, when as a family unit, being able to be able to accomplish a little bit more with a little bit more more ease. That's really is very significant when you have a medically frail child or a child that has developmental delays or things like that. it can take a toll on the child and the family. So we want to make sure that people understand that it has a huge impact to get these services for children when they are identified and how important it is. And so the process that we have developed does kind of have a step-by-step process, and it involves the care manager, CES, if they're involved, the local departments of social services, and also here at the state, the Department of Health. And so we all need to work together collaboratively. We need to have some good communication and making sure that these modifications or the process is moving forward. And if we have some bottlenecks or issues, we need to communicate that so that they can be addressed immediately. And that was our goal. It was really to address concerns and issues and the consolidation of all these services to streamline these processes, expedite the processes to get these accomplished. And there was a webinar yesterday held by CFCO with the local departments of social services to address their concerns about the fiscal impact that they may have in their county and how that may have delayed some of the approvals for these modifications. And so our Division of Long-Term Care and CFCO worked really diligently with the local departments of social services to expedite the payment processes. So we're hoping that this streamlined process plus the improvements, or I should say the new version of how to pay for these services by the local departments can expedite the services and get those services available to families. And once again, I'll just highlight the communication. You know, our DOH Health Home team and the Division of Long-Term Care, you know, if people are having concerns or problems, we'll be monitoring what's happening. But please reach out to us and let us know so that we can assist you. That's our goal here. So there's some effective timelines. So just a level set with everyone is that the children's waiver, the new consolidated children's waiver took effect on April 1st. So anybody in the children's waiver that is receiving home and community-based services is who we're talking about today. Those folks that will be getting EMODs, VMODs, and AT. But then on October 1st, the home and community-based waiver services of the children's waiver will be going into managed care. So once those benefits go into managed care and a child is properly linked and in a plan, then the plan will be responsible for ensuring that the child receives these services. If children are fee for service and they're not connected to a plan, then the process we're outlining today with the LDSS will continue as well. And as I already mentioned, our CFCO services will be launching on January 1st, 2020. And again, we're hoping that and wanting for these processes to be all the same and similar as these things happen. There was a recent draft of an ADM. It's going through its final phases, I guess, here at DOH. That is for the LDSS. So that will be, you know, posted on our website, and health home care managers and other folks can also read, you know, what the roles and responsibilities are of the LDSS and how that will work. And as I already mentioned, we're just very committed to, you know, making sure that these necessary services get connected to children and families, you know, as quickly as they can be. I mean, some of these things like a vehicle modification will take time, clearly, but we don't want the approval process holding things up. And then lastly, we've said this a number of times, if you already had some kind of modification that was in process, like from the previous Care at Home program or through OPWDD prior to April 1, then no one should stop those processes, right? You should continue, and those processes that were in place before the payment of those processes will finalize those. And as of technically April 1st, this is the new process. And I know that folks have been tracking with the local departments of social services anything new that has come in since April 1st. So if you're not thinking we're aware of something that came in before April 1st and you're now just learning of this, then please reach out to your health home or Division of Long-Term Care. Anybody can assist you so that we can make sure we understand what you've been asking for. And so we're going to go over through the process, and Tanya and folks did a great job outlining step by step. We just want to say that, and again, some of this will be very familiar, but want to make sure that everybody understands that the 6 previous children's waivers were all consolidated into one children's waiver effective April 1st. And for those home and community-based services. And to receive home and community-based services, you need to have some type of care management. And we have now linked HCBS to health home care management. And a family does have a choice to say they want to opt out of health home. And if they choose to do that, they still need some type of care management to get HCBS services. And that would be with our independent entity of Children and Youth Evaluation Services, which we call CES. So you will either be working with a health home care manager or CES staff. If you want some kind of modification or AT, they will be the ones who determine whether or not you're eligible for HCBS. And then if you are found eligible, they are the ones that, will work with the child and the family to develop that person-centered plan of care, which will need to outline, just like it would for any HCBS service, the specific EMOD, VMOD, or AT that would be necessary. And again, it's the role of a care manager or CES to coordinate all the services that surround HCBS, and for health home, it's a comprehensive plan of care, so it's beyond HCBS, but that is the role. And then the LDSS, we're asking to make sure that, this is a team effort, in that the LDSS assists care managers and CS to coordinate and make sure the paper flow is moving forward. So again, it's a team approach to make sure these vital services get connected to the child and the family. So I'm going to turn it over really to Tanya, who's going to walk you through, hopefully it will be very understandable, step-by-step process to make it easy for you.
All right, so starting the process, the care manager is going to meet with the family and assess, the need for one of these services, and they would put that in a plan of care just like any other HCBS service. They're also going to help the family secure a physician's order, so a doctor's order, stating this or supporting the need for that service. It could be a script, it could be just written documentation with a doctor's signature. And then they would assist the child and family to secure the clinical justification from the appropriate clinician, this meaning like the OT, speech therapist, it could be behavior specialist, and so on. It just depends on what kind of modification or assistive technology the family is looking for. They would also explore any payment sources, including private insurance, community resources, and other local and state programs that would pay for this product prior to requesting the Medicaid service. So they would have to, that is the care manager's job. So after they have eliminated the possibility of other funding, they would collaborate with the family and the LDSS to secure bids. So the LDSS should help wherever possible, but the care manager really should meet with the family and secure resources inside their community to get those 3 bids. And then they would submit all the necessary documentation to the LDSS. So the plan of care, again, is just going to review those steps and some of the components in those steps. The plan of care is the initial justification that the child needs the benefit or service. It also establishes that the service is necessary to enhance the child's independence, and Colette talked about the importance of the services previously. The care manager or CS coordinator should not only identify the need in the plan of care, but also a rationale on how it would impact the child's ability to achieve enhanced ADLs, IDLs, or tasks. The plan of care is also submitted along with additional forms when it goes to the LDSS, and that's in a slide further along. So after the care manager has put the justification together in the plan of care, they're going to get that physician's order. An example is an approved request for home care form, such as the M11Q used by HRA in the city, and that is probably mostly familiar to care at home folks, or the form 4539, or a letter on a physician's letterhead stating the need for the service. So I had said earlier it could be, like a script form, or it could be just on a letterhead indicating the need and making sure that it's signed by that physician. Clinical justification is that it's kind of like the evaluation rule where you send it, the occupational therapist or speech therapist has observed the child. They've looked at what kind of scope of the project is, if it's an environmental modification or vehicle modification, or they're identifying a specific product for AT. And they're going to have to come out and determine, the space and what is needed for that child to meet the goals in the plan of care. So, for example, installing a lift by the covered front stairs would be the best option for the child to fully access the entryway. And so that clinical justification, they're going to look at a few different options and go to, the least expensive but the most appropriate service or technology. And they're going to have that in writing so that the care manager can include in the packet going to the LDSS, they're going to include the plan of care, the clinical justification, and that doctor's order along in the packet. Again, the clinical evaluator is going to detail the scope of the project or the scope of the need for the technology and what kind of technology that is needed. They're also going to have to indicate how much the overall cost of the project will be. So all other resources must be exhausted before seeking the service. I think that was in a previous slide. So if there is funding elsewhere, the care manager would be able to address other community resources or eliminate them and then seek out Medicaid funding. So securing bids should be a collaborative effort between the family, the LDSS, and the care manager or CS coordinator. The 3 bids should be, from local contractors if possible, and they need to be based with contractor grade materials, stipulate all the work that is in the bid, and comply to all of the government and zoning codes. They must obtain a local municipality's permit to do the work, provide verifications the work has been inspected by the local municipality, and submit verification that the appropriate and adequate insurance is covered and maintained. And then all estimates have to identify costs of each component of the project, meaning inspections, materials, permits, labor costs, and any of the evaluation costs as well. If for some reason you cannot secure 3 bids, or then we just need to document why we couldn't get 3 bids. So maybe there was only one contractor in the area that got back to you. You just need to write that in a note that you're going to include into the packet, so that the LDSS can review the 3 bids, and all 3 bids need to go, not just the one that you like. So you send them all over to the LDSS, and the LDSS will take a look at the packet. So what needs to go in that packet? Again, it's the plan of care that identifies the needs, the physician's order, supporting that need, the professional assessment, supporting the scope of the work, the 3 bids from the contractors, and any required documentation is needed for the modification that would support a landlord's permission if it's a home that's leased, or proof that the car is less than 5 years old or less than 50,000 miles for a VMOD. Completed clinical justification with the description, scope of work, and cost projection form will be in this packet. If there's anything missing from the packet, there'll be communication back from the LDSS to the care manager. One way to expedite this process is make sure that you have all your stuff in the packet. So here's a visual of part 2 of the process. So we just talked about the care manager and CS coordinator getting that request for service packet together. They've sent it over to the LDSS. The LDSS is going to look at the 3 bids, select the preferred bid, and then execute a provider agreement with that contractor. They'll send it along to the Department of Health, and they're going to either support or deny the packet or the bid. But that will be with communication with the LDSS. So if there's something missing, they need more information, or maybe they did not agree with the selected preferred bid and they chose another one, they could pick a different bid in the packet. So the LDSS is going to issue a notice of decision, and they will send that out to the care manager, and the care manager will have to communicate that out to the family. And that notice of decision is either yes, you're approved for the service, or no, you're not approved for the service. So what's the LDSS's responsibility? They're responsible for evaluating the bids, selecting that preferred vendor. Again, the decision is based on assessment of whether the lowest responsible bid meets the assessed need of the child. So it doesn't always have to be the lowest dollar amount. It has to meet the child's needs, and then the one that meets the child's needs that is the lowest would count. The LDSS will contact the selected vendor and secure a provider agreement so that the service request may be processed upon approval by DOH. The LDSS collects all of the documents and submits the service request to DOH for review. And so what goes in that packet? The LDSS is going to submit the entire packet. So they've received the plan of care from the care manager, the physician's order, the professional assessment, the 3 bids, and then they're going to add the provider agreement, additional documentation from the care manager on landlord's permission, and proof that the car is less than 5 or less than 50,000 miles. The completed description and cost projection form and justification for the need if it exceeds that soft service limit of $15,000. And it says, note, the department may request additional documentation and information as needed. This is a fluid process, so if there's something missing or additional information that any of the partners, meaning the care manager, the LDSS, or the Department of Health requires, there will be ongoing communication back and forth. So the LDSS will not submit a request to DOH if it's not approved. So if there's not enough support to support the request, it won't go further. Once the DOH receives the packet, they're going to acknowledge that receipt with the LDSS. So we should be able to track, how long these requests are taking or where the request is in process. They're going to review all the contents for completeness, accuracy, and cost before they get back to the LDSS. And again, they're going to, if those things are not complete or there's something missing, they will communicate back to the LDSS for that information. And the LDSS may have to contact the care manager for additional information as well. So when DOH comes back with either an approval or not, they're going to communicate back to the LDSS that determination. Upon review of the information provided, DOH will send a letter of support or denial for that project. And then upon the receipt of the letter of support or denial, the LDSS will issue that notice of decision. And that notice of decision is going to indicate, yes, you're either authorized for the service or no, you're not. All of those notice of decisions are subject to fair hearing when requested, and this process is explained to the waiver participant and family during discussions with their care manager or CES coordinator. So notice of decision is a written document, again, that notifies the individual of the action being taken. So that means the LDSS is either approving or not approving the project or request. So upon making determination about a request for services and receiving prior approval from DOH to exceed the soft limit, again, of the $15,000, the LDSS is responsible for sending a written NOD indicating authorization, denial, or reduction of the service to the legal guardian as well as the care manager. Again, when those NODs go out, they will have fair hearing and right information on them. So the LDSS has, in this slide, has authorized the service. So they're going to communicate that to the care manager. The care manager is going to communicate to the family, your service has been authorized. And then they're going to communicate with that selected provider that the LDSS and DOH agreed on. The EMOD, VMOD, or AT provider will review the bid, start the project, and then subject their project upon completion to an evaluation. And then they're going to have to fill out the final cost form because we do recognize that with any kind of building project, sometimes there is an increased cost, maybe material costs change or something like that, or it took longer. So there's increased labor costs. So they're going to have to fill out that final cost form and send it back to the care manager. So this kind of just reviews what I just discussed. So the care manager or CS coordinator advises the family of the decision, discuss the next step. So sometimes the next step, families have decided not to go forward, and that's okay. So they'll have to have a conversation before they start the project. So the care manager or CS coordinator works with the family and the selected vendor to initiate the project if they decide to go forward, including reviewing the bid and the terms of the project with the vendor. The provider or vendor will be responsible for the coordination of the project with the LDSS, because that's where their contract is with, and they'll provide detailed information regarding expenditures, compliance requirements, and project timeline. Throughout the process, the care manager and CS coordinator or CS coordinator will work with the family to ensure their cooperation to allow provider or vendor workers in the home and be able to complete the work. So we want these things to be done in a reasonable time frame, but we also want to make sure that the vendor is able to be on site to do the work, particularly for environmental modifications. Additionally, the care manager or CS coordinator will ensure that the work is completed as agreed and that the family is satisfied with the work. So that's a conversation between the family being satisfied with whatever work has been done and reflecting with the clinical justification or evaluator, making sure that the project is done to scope. So the care manager in this illustration is receiving the final cost form that they have received that from the vendor. They are going to send that along to the LDSS, and the LDSS is going to review and then send it over to DOH. As long as everything's good, they're going to approve that cost adjustment and payment, and they're going to issue a notice to the LDSS so that the LDSS knows that we can process payment to that vendor and that payment will receive their payment. So this is just the words that go with that illustration. So again, the final cost form is submitted to the LDSS. The form will include a description of the completed service and the final cost. The LDSS must maintain the form in the child's case file and send a copy to DOH when completed. The LDSS will review and the submitted form and validate the completion of the specification of the bid and purchase. Once validated, the LDSS will notify the provider that they may submit a claim for the payment, and then the care manager will provide feedback to the LDSS regarding the work of any concerns they had with the project. So service limits I've mentioned a few times. It's $15,000 for assistive technology, environmental modifications, and vehicle modifications. That's an annual calendar limit. These are also soft caps, so in some cases, it's particularly environmental modifications and vehicle modifications have a tendency to go above $15,000. That's fine as long as it's justified. It's in the you've put it in the scope, and then it goes along for approval from the LDSS and DOH. So Colette had mentioned that there has been some work on streamlining the process and moving the process forward a little bit smoother, and part of that work has been done cleaning up the payment process between the LDSS and the contractors providing the work. So we have a couple different payment options that we discussed with the LDSSs yesterday, and it should help the process move along a little faster as long as all the paperwork and specifications are detailed and outlined in all the forms we just discussed. So as long as the paperwork's good and it makes sense, then it should be a little faster than it has previously. So information for the LDSS, they know that there was a few requests from LDSSs to attend this webinar, and this webinar does not include some of that payment detail or option information. So there was a webinar yesterday from the CFCO team that did capture the payment options, and once posted, it will be at this website. And the forms can be found on the CFCO website currently, and once they're all final and good to go, we will also post them on the children's site. So you can take a look at those there, for example. All right, so I'm going to turn it over to Faith Moore, who is going to discuss non-medical transportation. We have previously had a webinar. This is actually part 2 of the HCBS series that we did in March, where we reviewed EMOD, BMODs, and ATs. Those guidelines did not change, but we did not get a chance to review non-medical transportation, so we'll do that today, and then we'll go to questions.
Okay.
I'm just going to go to 51.
Okay. Thank you.
Oh, 37, sorry.
First of all, we're going to start with what exactly is non-medical transportation. It's an HCBS service that authorizes individuals to get to destinations that are related to a goal that's included on their plan of care. Now, this is offered in addition to any medical transportation that they would have available to them under the state plan. The difference here is that non-medical transportation includes transportation to places that are non-recurring, and examples of that could be if a child or a youth needed transportation, for instance, to a job interview. Maybe they need to go to the library to get information on how to get into a GED preparatory course or attend a wellness seminar. There are a myriad of examples that we could give, but the most important thing to remember here is this transportation is non-recurring. It is for a specific goal that is on the youth's plan of care. So the health home care manager's role in this is, first of all, to help the family and the child or youth member to determine what their individual goals should be. That's the justification within the person-centered plan of care for this service. That goal should be specific and related on the plan of care. When that plan of care is delineated specifically, it'll have the actual activity, support, or task that it refers to, the service provider, if that's part of the goal, and a start and end date, along with the contact information that might be needed by the transportation manager for clarification. The healthcare manager will complete the plan of care. They'll also complete a grid that will show exactly what the service will be, and those will be sent to the MCO if the child or youth is in Medicaid managed care. At that point, the Medicaid care organization would be responsible for approving these plan of care and for forwarding that grid on to the Department of Health's Medicaid Transportation Manager. If, however, the child is not yet in a managed care plan, then the care manager would send the grid directly to the transportation manager for review. Then so it is the care manager's responsibility to fill out the New York State Department of Health Plan of Care grid for non-medical transportation for children's HCBS services, which we'll refer to as the grid after this, with all the information that they're aware of about both the member and their trip request. It is possible, because this can be done quite a bit of time prior to the actual date of the trip request, that not all the details may be known at the time. So it is important to remember that you need to allow at least 72 hours in advance of the appointment date to request transportation, and that's a minimum. The CS coordinator role is very similar for all children who have decided not to be enrolled in Health Home. The CS coordinator would work, again, with the individual and the family to first determine if there is a need for non-medical transportation, and then to develop the person-centered plan of care with the specific goals that are directly linked to that service. And the CS coordinator, just as the Health Home Care Manager, would be responsible for completing the grid and forwarding both the grid and the plan of care to the transportation manager or the Medicaid plan if the child is in Medicaid. The grid will include documentation for non-medical transportation, including documentation of which goals in an individual's plan of care are directly supported by that trip. CS coordinators are also responsible for developing a plan of care, just as care managers in Health Home are. So that justification of that service is documented within the plan of care. And the CS coordinator completes the grid and forwards that on to the transportation manager. Again, if complete details aren't known, then they would provide those details at least 72 hours in advance of the date of the trip request. And the CS coordinator would also list the goal, the activity, support, or task, the service provider, if there is one, the start and end date, again, exactly as the health care manager, Health Home Care Manager would do. For the managed care organization roles, the managed care organization is responsible for approving the person-centered plan of care and for forwarding that grid once it is approved to the Department of Health's Medicaid Transportation Manager. If, however, the child is not yet in a managed care plan, then that grid would go directly to the Medicaid Transportation Manager for the review. For the Transportation Manager, they are responsible for authorizing the transportation services as it would be approved under Medicaid policy and with approved Medicaid transportation providers as it is supported on the provided grid. Once the manager receives the grid, then they review and approve the grid itself with the individual's plan of care. The transportation manager is responsible for adhering to all the guidelines for non-medical transportation, which include ensuring that the most medically appropriate and the most cost-effective mode of transportation is selected. So that would mean that the safest, medically appropriate, and most cost-effective mode would be used. It might be an ambulette, a taxi, public transportation, depending on the child or youth's need and goals. The transportation manager will also be providing a monthly report of the non-medical children's waiver trips in a format that is requested by the Department of Health. Now, some of the children and youth that will be using this service will be under the age of 18, and in that case, they would be considered a minor child, and if they have not been emancipated by a court system or have otherwise not qualified as being emancipated, they will need to have an adult escort. The transportation grid that is provided does have a place on it so that you can indicate that the member is a minor that requires an adult escort, and it also allows for you to place contact information by either the health home care manager, the CS coordinator, or the managed Medicaid care manager who completes the grid, so that that transportation manager will know who they can access to seek additional information prior to the trip, if necessary. The adult escort is someone that does not have to be related to the child or youth, but they can be, but it's not necessary. For those youth who are under the age of 18 but who are consenting themselves because of being either pregnant, a parent, being married, or having been declared an emancipated youth by the court system, they would be using non-medical transportation without an adult escort. In that case, both the plan of care and the grid should specifically indicate that although the youth is underage, they will be traveling without an adult escort. This grid then has a place to indicate whether a child or youth is accompanied or not. Where it is noted that a child or youth is emancipated, the grid would be marked as the member is traveling unaccompanied. And the transportation manager can confirm that youth status with the health home care manager, the CS coordinator, the member, or the family prior to any trip request so that they can clarify exactly who will be transported. In the case of a minor parent who is traveling on non-medical transportation with their own minor children, it is the minor parent who is the emancipated youth, as long as they're self-consenting under health home or CS guidelines, that it's stated in their plan of care and on the transportation grid that they are to travel as an unaccompanied minor for non-medical transportation trips. And in that case, they would be their own escort for their children. Under limitations and exclusions for non-medical transportation, here the same rules apply that determine reimbursement of trips for medical appointments. So it would be essentially the same. However, only those services that are not reimbursable under CFCO would be reimbursable under the HCBS waiver. In general, for non-medical transportation, the following guidelines do apply. This transportation must be tied to a specific goal in the plan of care. The transportation is available for a specified duration, an annual cost, and individuals who are receiving residential services are not eligible to receive non-medical transportation. Also, the use of the transportation is available free of charge and would be with the most medically appropriate and cost-effective mode of transportation. Travel is generally within the common marketing area, and wherever possible, trips should be combined. And if there is a need to travel beyond the common marketing area, you can use Form 2020 to establish that it needs to be outside that immediate area. For claims for personal vehicle reimbursement for non-medical transportation, it's important to know that you need to get prior approval from a transportation manager. The way to do that is to call the transportation manager and receive an invoice number for every trip that you would expect to be reimbursed for. And they can also provide you with the reimbursement forms directly to be sent from the transportation manager, or you can also obtain them from the websites, whether that is Medical Answering Service for upstate New York or Logisticare for the Long Island area. And that contact information is going to be provided at both the end of this presentation as well as within the manual. Claims for personal vehicle mileage reimbursement are generally to be submitted within 90 days of the service, along with the required mileage reimbursement form, and any original receipts for expenses for things like parking and tolls should be attached to the reimbursement form. It is possible to consider reimbursement for trips beyond the 90-day period, but only if there are extenuating circumstances, and those cases would be looked at on a case-by-case basis. Reimbursement for travel can be denied when the destination does not support the participant's integration into the community if it's not directly related to that plan of care goal. And the participant's plan of care should outline the general parameters of their non-medical transportation needs. It is understood, however, that those needs can change and will change as the members' goals change or as their needs change. So this can be fluid, but it does need to be documented within the plan of care. Agencies that can provide non-medical transportation must be enrolled in the fee-for-service program as a current Medicaid transportation provider. And below you will find the links to the transportation provider manuals as well as an enrollment application for transportation. And as I said before, here is the information on how to access Medical Answering Service, which is the provider for upstate non-medical transportation services. And then Logisticare is for the Long Island area. And should you need more information about how to access non-medical transportation or some of the specifics about the service, you can always check with the Department of Health Transportation Unit for specifics at this email.
All right, I'm going to turn it back over to McTaff for a second so we can take a look at the questions and we can start answering some of those.
You might want to go to the, at the end where you have
All right, thank you. While we give the presenters a few moments to get organized around the questions, again, just a reminder that if you have any questions, you can submit them via the chat box function. And so we're just going to give them a few minutes, and then we will get started momentarily with our question and answers.
So thanks. So the first thing I want to just highlight for folks, because there's a couple questions, is for the EMODs, VMODs, and AT, if a family or a child needs more than one, then they need to be all separate, right? Separate bids, separate documentation. So they should be sent to the LDSS as a separate request. So there was a couple questions about how to do that and the various limits, the soft limits of $15,000. So we just want to make sure that if a child has more than one need, that you work them as separate items. They would go in separate packets, separate clinical justification. If you have clinician or clinician justification from a person who can do more than one of those justifications, that's fine, but they would have to be separated and in separate packs. So I also want to say the $15,000 limit is also per item, right? So $15,000 per an EMOD, VMOD, and then an AT. So again, if a child needs more than one, you have a limit, a soft limit of 15 on each. And then there was a question whether that was a calendar year. So that is a calendar year. It's not a fiscal year or anything like that. So if you got a modification within 2019, that's what we would be looking at. And then in 2020, it would be starting a new year. Again, we understand that some modifications will exceed the $15,000. That's why we say it's a soft cap, but we would need that justification why it would need to occur. The other question that has been asked is regarding payment, and that some vendors or contractors may need like a payment up front for supplies or materials. So that needs to be communicated with your local Department of Social Services, because every contractor or vendor may work a little differently. Some vendors may say, I need the money up front for materials. So there is the option for the local Department of Social Services to break out the payment based on those needs of the contractor. So the goal is really to have that conversation with the contractor when you're getting the 3 bids. The contractor or vendor should write in their bid that they would need that upfront money, so that if they are the selected bidder, then the LDSS would know that right up front and would also have a projected cost for those supplies. And we have given the flexibility to the LDSS to do those upfront costs. And then there was a question about the clinical justification. So in the slides, it says who those folks would be, whether, and it really depends on what the request is, right? So, you know, it may be, I think on there was a behavioral health specialist or an occupational therapist or something like that. There was the question on whether or not that could be the physician that also wrote the script. Well, if that's the person that has the information and is in your home or has that ability to write that, then it could be the same person. Again, it really depends. It's hard to, you know, clarify depending on, unless you had a specific example. Our goal is wherever you can expedite the process with one person versus 3 people, as long as you have that justification, then I believe we would accept that. If you have a question, you're not really sure, then I would call your local departments of social services, or you can call here at the health home team or the Division of Long-Term Care. Again, we're here to help you. So if you're concerned up front, then I would say, reach out to someone and then get that clarification right away, and we will try to assist you as quickly as possible. One of the other questions was about the timeline, that once you submit the packet to the local departments of social services, and the local department of social services gets that to New York State Department of Health, what's the turnaround time? So again, we have not put specific turnaround times because it really depends on what the situation is, and if the local Department of Social Services would need more information. What we don't want to get into is you didn't meet the timeline, so it's denied, right? So it's really important. As we mentioned, we will be monitoring how long this is taking, the number of requests, and if people are concerned that the time that's being turned around is not quick enough, then I would again ask you to reach out. If you've submitted a request to your local Department of Social Services and you haven't heard anything, then again, I would ask you to reach out. You could reach out to the local Department of DSS and find out if they even submitted it to DOH yet. So again, I think our goal here is to put out a streamlined process, get everybody familiar with it, working under the guidelines, and then addressing any bottlenecks or problems. And then at some point, if we need to put timelines, we could always do that. But we didn't want to pressure people or delay things because timelines weren't met. We've all committed to doing turnaround as quickly as possible. And again, would love to hear your feedback as this is moving forward. So folks are asking about the role of the managed care plan. And again, as we mentioned, these services are currently not in managed care. So this is fee-for-service. So this is all going through the local departments of social services until October 1st. Right, and then HCBS services, home and community-based services, are going under managed care, but there will still be kids fee-for-service. So one of the main things that a care manager should be doing for all children, not just children who want a modification, is after April 1st, making sure they're connected to a plan and asking them who their plan is, because that is who you'll be talking to as a care manager. That is who the family should be talking to if they have problems and questions with any of their benefits. So we should all know who a child's plan is, but until October 1st, these services are not under plan. Once October 1st hits and a child has a plan, has a plan benefit card, then these modifications in AT will go through your plan and not the local departments of social services. Somebody's asking about slide 11. I don't remember what that is, so. Okay.
All right, slide 11, what is the question?
It just says, can you clarify slide 11 is pre-managed care?
Slide 11 is on plan of care. So plan of care applies no matter what. So that plan of care needs to reflect the needs and be documented and forwarded into that service request packet that we discussed. So that applies to everybody.
So right, any child who receives HCBS services needs a plan of care by their care manager or CS. And the process we outlined that the plan of care needs to go to the LDSS is prior to someone being into managed care. So once we hit managed care on October 1st, there will be a plan of care process, workflow that will be specific to managed care. So I hope that clarified that. And Tanya did not, and Faith and folks, did not go over the service definitions of EMODs, VMODs, and ATs, their limitations and exclusions, but they are in this slide deck because we wanted to make sure there was one comprehensive slide deck. It's also in our HCBS manual. So if there's a couple questions about what's covered, I would refer you there. And if you're still unclear, then again, I would ask you to reach out to us. So there's a question about if a child's jumping on a bed and their springs break and things like that. So I would go look what is covered under EMODs, VMODs, and AT.
There was a question on repairs as well, and these are intended to be one time, and that is in the guidance that Colette is referring to. And limits and exclusions under each of the services are actually exactly the same, but under certain circumstances, the Department of Health and LDSS will consider a second modification, but again, it's just reaching out and finding out if we can cover that. Because some of these services and because the services and not the AT can be vastly different, it's hard to answer that question, so just reach out.
And I would say that please reach out prior to expending the money from your agency because there will be no guarantee that we can reimburse you, okay? So that's very important because there is a process, right? So that is important to know. There's also a question about contracts. So there is no requirement for a health home care management agency or CES to have a contract with the local departments of social services. What will happen is that the local departments of social services will have a service agreement with the awarded bidder. And somebody asked for a sample or a template. So I believe that there was a template that was developed and sent to the local departments of social services that may have been attached to the ADM. I don't know. I don't know. But the local departments of social services, that's their responsibility to do that service agreement or contract with the bidder who's awarded. So in that template or example has gone to them as they would be executing that. It's really important also, we didn't really mention this, but you know, there should be all this documentation and correspondence, right, in the care manager's plan of care, their progress notes and things like that. Feel free to make a copy of the bid or do whatever you feel necessary to make sure that you have that in the record if you're concerned about that.
So there was just somebody asked for clarification. Yes, any kid who is in fee-for-service after 10-1, there will be some, will continue to use the LDSS.
So there's a question about whether or not there's a list of point people from each of the LDSSs and after October managed care. And so I think we're going to have to bring that back. We've been working really hard in our Division of Long-Term Care has been working diligently on a weekly basis with the LDSSs on a number of things. And so we'll bring that back and see, because I agree that that might be helpful if you know where you need to send the materials and how and who you should communicate. So we will file that away and get back to folks. There's also a question about the clinical evaluator and how they will get paid. So on the slide, it did mention that the clinical evaluator, along with the 3 bidders and the one who is awarded, is all of the total package for the modification and is available to be paid for. So again, you know, you would need to have that discussion with that provider, whoever it is, whether it's the behavioral health person, OT, PT, whatever, and ask if they charge a fee, because many may not, right? So you want to ask if they'll charge a fee. They're already in the home working with the child. They may not charge an additional fee because they're already in the home. They're already making an assessment of the child. So many may not charge a fee, but if they should for some reason, then you want to know that ahead of time how much it is, and then if they want to be paid in advance after their part of the job, I guess, is done, then again, that is a communication that you need to have with the local Department of Social Services, that you would be submitting that portion of the bill ahead of time and would want that upfront payment to that individual. Many of the evaluators, though, understand that it's part of a package deal and need to, would understand if it's part of that, and then whether or not a bidder was chosen or not. And as the slide mentioned, that if the EMOD or VMOD does not move forward, whether it's not approved or the family then declines, it does not mean that the clinical person, evaluator, would not get paid, right? So they've done their portion, they would still get paid even if the project doesn't move forward.
There's several people indicating that the webinar yesterday was canceled. I'm not sure what that means. There was definitely a webinar yesterday with the CFCO group, and those slides will be posted. So you can reach out to the BH Transition mailbox or the CFCO group. They have a mailbox as well, and we can get those slides sent back around.
Yeah, I think the invitation to the regular meeting was canceled, but there was a registration for the webinar, so that might be some of the confusion. So there's a couple of questions about non-medical transportation, my friends. Is non-medical transportation Access a Ride?
No, it is not Access a Ride. That is a program, Access a Ride is an MTA-offered program down in New York City, so this is different. New York City is handled by our transportation manager, medical answering services, so they would be the folks that you would work with to secure your non-medical transportation. Also the same population that they work with to secure their medical transportation if they are in a fee-for-service Medicaid.
Okay, thank you.
You're welcome.
And then, can non-medical transportation be used for recreational activities if a goal is to attend a community rec activity to promote like socialization or peer interaction?
As long as the activity is tied to the plan of care and it's going to benefit the child, you know, like social, developmental, something like that, yes. So it just has to be tied into that care plan somehow.
Right. Can parents who transport get mileage reimbursement for non-medical transportation?
Yes. Again, that would also need to be on the care grid, that they're going to be self-driven, and then, you know, things like that.
So this is really important for care managers and CS to make sure you look at the slide, because I know Faith went over it, that, you know, that has to be pre-approved and everything. So you don't want parents transporting their kids all over the place and then asking to be reimbursed, and they will not get reimbursed if they do not follow the process. So that's your responsibility as a care manager, to make sure our families know how they can properly get reimbursed, and hopefully you can help them through, you know, whatever hoops or documentation that they need. And as already mentioned, you need the plan of care that you wrote with the family. So that's really important that people understand that. Okay, how quickly will an approval for non-medical transportation be turned around? I heard 72-hour lead time, but there seems to be far more steps involved in getting approval. It seems difficult, blah, blah, blah. They just want to know around the time period.
And that, I'm going to tell you now, is subject to change. There are other forms that might be required to go with your plan of care, or the grid, as we call it. If, for an example, the child needs to be transported by an ambulette, they're going to need to have what we call our 2015 medical justification form filled out. That basically just speaks to how their condition impacts their ambulation and ability to access transportation types. So if there's somebody that requires that, there's going to be an extra form that will be filled out. Additionally, that common medical marketing area form that we talked about. So if there's not a program available for that goal in your general geographic area, and you have to go, let's say, 5 counties away, that would need to be filled out, again, by your referring provider or your referring person, not the receiving end of things. Normally those things, I always say 5 to 7 day turnaround time. They don't normally take that long, but just to give you that cushion, that's what I like to advise. I will say that going forward in the summer, a lot of these forms are going to be up on our online system, whereas now they're not, and it will be electronic and therefore a lot quicker of a turnaround time.
Awesome.
So that's to be determined and subject to change.
Okay, so once that happens, or when it happens, we'll make sure we send everything out to the listserv, and you all are aware that it can move along a little further. There's a question also about you reference a potential annual cost limit. Can you tell us what that means? I don't remember.
No, there's no.
Not with transportation. Maybe they're talking about that $15 or $15,000.
No, they say non-medical transportation. Okay, so whoever asked that question, there is no cost limit, annual cost limit for non-medical transportation. So apologize if we were confusing. I'm just looking, since we're on the transportation bandwagon, get it? Can you please confirm if the non-medical transportation service will be handled by managed care plans as of 10/1?
No. At this time, all of transportation, with the exception of Rockland County Fidelis, is carved out fee-for-service. So any place else in the state that they might live, they could have a managed care plan. We're still going to handle the transportation from our side of the house.
Okay, so it's really important, since we've been mentioning the 10/1 managed care for E-mods, V-mods, and AT, that the managed care plans, HCBS, is going into managed care plans. So non-medical transportation, which is an HCBS service, will remain fee-for-service. So these processes will remain intact beyond October 1. So we'll just make sure we keep highlighting that for folks, but that's important. Make yourself a sticky note or whatever, so you remember that.
And again, as I said, if they're a child living in Rockland County Fidelis, that would go through Fidelis, but everything else is statewide transportation managers.
So when an appropriate is there a time when the appropriate method for non-medical transportation is public transportation? Like, do you get a Metro card? Is that something that's allowable?
Depending geographically where you live, Metro cards obviously are New York City. That is an option. So if somebody is ambulatory and able to access the train or the bus on their own without any kind of assistance, or I guess it would just be assistance. I don't think they have adaptive devices, but that would be an option, definitely.
Okay, and then who distributes those? Like, do they go through the same process?
For this particular process, it's going to be a little different than our medical. In the city, for an example, medical goes right to the facility. They get a Metro card. These folks are still going to need to use this care grid for non-medical and still go through our transportation manager. Geographically, no matter where they are throughout the state, we're going to need them to do that for now. Only time I can see that potentially changing is maybe 2020 when MTA goes to a reloadable Metro card. The process could change then, but at this point we have no anticipation of that happening.
Okay, so all you need to know is this is the process, right? So this is the process, the grid, use these slides. It's all fee-for-service beyond 10/1, and for Metro cards, for parents to get paid, or if you're going to get an ambulance or other service for non-medical transportation, this is the process until you're told otherwise.
That plan of care is your lifeline for non-medical transportation.
Excellent. Looking. You don't see any more either? I'm trying to get all Amy and Faith's questions here.
And if there's nothing else for us at this point, you can always reach us in our BML. I believe that's on here, as well as, our contact information. We're always available, as are our transportation managers.
Great. So there's a question, If there's not an evaluator or a clinician in the home, what should someone do for a modification for that clinical?
Clinical justice.
Thank you. I couldn't think of the word.
So the care manager is going to have to coordinate with finding those clinicians in their community or an evaluator if that county has an evaluator.
So I think the best course of action I would recommend for a health home care manager or CS is you would have that doctor's script, right? Or, you know, the family has met with their pediatrician or whoever they're working with. You've talked to them. So if you're concerned about not having the available people in your community, I would talk to the physician to see what their knowledge is. Can they assist in this? The other thing is we would assume that, you know, based on the ADLs that you're trying to accomplish, that you would also be referring to a clinician if one's not already involved. So when you're making that referral, that you want an OT or PT in the home, then you may also say that the physician is supporting a modification. And so that person, when they do their first intake or assessment with the child, could also maybe do that assessment of the home at the same time. So again, if you're having problems, I would say to reach out to us. If a child is at the HCBS level of care, they should have professionals involved with their care and their behavioral health. So we're hoping that there'll be those potential professionals available. But if you're finding that's not the case, then I would recommend, if you've exhausted everything, to reach out to us. There's also a question about the forms. So as Tanya mentioned, the website of CFCO has all the forms. Yes, they do say CFCO on them. Yes, you can use them for the children's waiver. The goal was for CFCO to launch prior to the children's waiver. That did not happen. That got delayed. Really? Delayed in New York State? I don't understand. So, and again, we're all working together. So we're all trying to have one process, as we mentioned. So yes, you can use those CFCO forms. Use our HCBS manual for information. So it's all one process. And as Tanya mentioned, we will get that on our children's site with all of our other forms for HCBS. And then once all the forms for non-medical transportation get electrified on the website, we'll make sure everybody is aware of that, and our children's site will link to that or something so that people aren't hunting and pecking all over the place to find things. And I think you answered this question, Amy. So must a child have a 215 form on file with transportation manager before submitting the transportation grid?
They can submit it at the same time, but they will be required to have one if they need, obviously, anything higher than the public transit.
Okay, great. So I hope that answered the question. The second part of that question was about the MCO, and as we already mentioned, transportation, non-medical transportation is fee for service even beyond April 1st. Anything else?
October.
Did I say, oh, sorry. Yeah, that's what you need, is me confusing you. October 1st is managed care, so apologize for that. I think we're just taking a minute to look to make sure we answered everything because I jumped around to.
So there's a question here that says, for kids connected to health homes, will both the health home and MCO each need to develop a plan of care? Or can the plan of care developed by health home care manager be used?
So there's one plan of care, peeps, okay? So whether you, remember health home is comprehensive, so it doesn't matter how many players are involved with the family, how many professionals, There should be one plan of care. We will be issuing the workflow for that plan of care when you're working with an MCO. So there's not separate plans of care. Remember, the health home care manager or CS is determining whether or not the child is eligible for HCBS. And by determining that, they have already done some type of assessment with your family, gotten to know your family, so they should know what your needs are, and over time also updating that plan of care so there's one plan of care, and when managed care gets involved, like I said, we will be issuing an updated workflow where you, as a care manager or CS, will be getting that plan of care to the MCO.
There's also a question, do we need a doctor's script and clinician's justification or report for EMOD? And the answer is yes to that. And there's also a continuation on that question. It says that they currently wouldn't need it if the person is no longer a child. These services are specifically for HCBS eligible children that are 0 to 21. So if they fall into that category and receiving HCBS services or eligible for, then it's 0 to 21, and they need both.
So if the service is respite and the goal is to give the family a break and the family doesn't have a vehicle, can they use non-medical transportation to get to respite?
That one I might have to actually take back for you because we don't normally cover transportation for respite. Whether or not that will be something that is accommodated in this, if it's tied to the plan of care, we will have to double check.
Okay, so we will get back to folks about that, as well as the other items we had mentioned, and, you know, we'll issue something of affirmative or denial of the answer to that question.
There's also a question about if the child's already in managed care today, would they take care of the EMOD or wait till 10-1? So the services themselves are not in plan. So you have to wait till 10-1 for the managed care plan to help you with all these services. Otherwise, it goes to the LDSS.
Yes, please don't wait till October 1st to get your child a proper modification. If they need so, right, use your LDSS in the process we outlined today. We're just saying who's going to end up paying for it and making, you know, these step-by-step arrangements with the contractor. So right now it is the LDSS, and once these services go forward under managed care on October 1st, that would be managed care if the child is in plan, right? There will still be fee-for-service. So any kid fee-for-service beyond October 1st is still the LDSS, and any other kid after October 1st would be managed care, but please do not wait. Right? If there is a needed service, let's move that along. So somebody's asking a question about forms. I'm not sure if I understand that question, this one up there. Okay, so other funding should be explored. I don't know what the form, other forms. Is that, I didn't know why they were quoting it.
I don't know, maybe there's a typo.
Okay, so maybe we have a typo, so thank you for alerting us to that. So it is the responsibility of the family, the care manager, CS, to see if in the community, their insurance, if there's another way to pay for the modification or the AT. So again, there may be that availability. Some companies and other areas may even provide a service free of charge or at a low cost or something like that. So as I believe it says in the slides, we'll double check, you as a care manager need to document that that has been explored. So you would just, you know, list out, we've explored X, Y, and Z. There's nothing available in this area or for the family or through their insurance. And then that goes part of the whole packet and the whole justification for the need along with your plan of care and things like that that were outlined for you. So there's not a specific form that you need to fill out. So we apologize if that was confusing. So I'm just going to read the question. So the question is, are eMOD's AT providers considered the actual vendors or contractors, or the provider someone who oversees the project and pays out the respective party? So the contractor, the vendor, I guess, or a provider, because it really does depend on what the item is that you're trying to accomplish, would be the person who's doing the work, okay, or the agency or contractor that's doing the actual work. So you need a ramp on your home for a child who has a wheelchair, then that contractor, provider, whoever, will come out and say, we'll write up a bid, you know, how much materials, how much wood or whatever it will take, how long the ramp will be, things like that. That is the person who is doing the work. Then there needs to be an evaluation, okay, of that bid, and that is done by the LDSS and then New York State, right? And then it's awarded. And then as the project is started and then throughout the process and then finished, the care manager, CES, the family are all in discussion, making sure things are going good. And then there needs to be a final evaluation that everything that was outlined and that will be paid for was actually done, right? We don't want to pay for a half a ramp that doesn't accomplish anything, right? So there needs to be an evaluation that what was going to, or what is being paid for was actually accomplished and that everybody's satisfied, right? It's just like what you would do at your own home. You wouldn't want to pay for half a job, right? You want to make sure that it gets what everybody thought was going to happen and what was written down in the bid. So there needs to be an evaluator. So that can't be the contractor or the person that did the work because they're just signing off on their own work, right? So again, this is a team effort, right? So the LDSS and the care manager, CES, can all be working together. The family's ecstatic, the ramp works, we tried it out. The care manager is happy, and they're notifying the LDSS. Some counties have evaluators or an inspector at the county. I mean, there's all kinds of avenues that could go through. So that is the discussion you want to have with your local Department of Social Services to make sure that you understand what they have available and how they will evaluate the job well done, okay? And if they need you services as a care manager, then they'll have that discussion with you. The goal really is everybody gets what they need and they're all satisfied at the end of the day. Nobody wants to pay for work that's not done correctly. So that is the goal. And we understand that some counties might not have a lot of resources or in rural areas. So again, that's a collaboration between all the parties to make sure the work gets done. And again, any communication with the state here of your thoughts about how to streamline something or if something's not working, we're here to hear that so that we can adjust whatever process to streamline whatever we need to. So I think we're at time, and I'm not really seeing any other questions. So, McTack?
Yeah, thank you, Colette. We are out of time, but just a reminder that the slides and recording will be made available on our website. So after today, I know there's a lot of information that was presented, but you should be able to access it there. And we want to thank you all for joining us this afternoon, and we hope you enjoy the rest of your day.
Right, thank you.